Welcome. My name is Nicolas Aronna. I am from Spain, and I'm going to present in this case discussion a GBR performed in a three-dimensional defect combined with adjacent one-wall defect. We are going to present also specific materials and biomaterials that I used in this specific case, and how the economic limitations of the patient forced us to use a specific combination of biomaterials to try to be as much predictable as possible. So we had to basically trust on our skills and on our biologically oriented sense of diagnosis and treatment planning, as well as management of the tissues in order to be predictable and overcome some, complications that usually you can expect sometimes, especially when you are performing a surgery in such a difficult cases and such difficult scenarios. So this is the case that I want to present. This is a patient that came with some pain on the upper left first premolar, number 24, for the Americans, number 12 tooth. This patient came to us. It was basically a case that I treated in a French clinic, in a French clinic, and this patient had that apparently endo treatment that I don't even see it, but a long time ago, and the patient had some post-encore and probably that periodontal problem that the tooth developed was because of a fracture development of those metal chrome cobalt metal post-encores. And one of the things that I usually take into account, and I make it important in situations like this, is what do I do now? Do I extract the tooth and wait for the soft tissue grow? Do I extract the tooth that is affected or the adjacent tooth, such as the canine, which has developed a one-wall defect from the distal aspect, in order to get more bone to regenerate and have more potential of especially the walls that are going to feed up my graft. The second premolar is not periodontally affected, and I know that tooth developed a crack, and that was the reason why this big severe periodontal defect developed. But at this point, we need to have into account what do I do now? Do I extract the tooth and place an implant? Do I extract the tooth and wait? Do I extract the tooth and extract also the canine, as I said before? Well, in this case, what we decided to do was to extract the tooth and wait for the soft tissue growth, because I know that periodontal defect is a type 3 severed. And I don't have any height, I don't have buccal plate, I don't have palatal plate either. And also, in addition to that, I have a periodontally compromised tooth, which is the canine, that I decided to keep in this case because it wasn't mobile. And I considered that staging the approach and not doing crazy things, such as in this case that I don't have any bone graft or hosting bone to host my implant. I don't want the body to do too many things in one shot, too many things in one time. So I decided to extract the tooth and wait for 4 weeks for the soft tissue grow. I took a CT scan, and this is what you see. I have a 10 millimeter buccal wall that was lost, and also some distal wall of the most distal aspect of the canine. So at this point, this is what I have, and we decided to do this in order to gain some soft tissue. As I said before, we are going to stage our approach. We're not going to ask the body to do too many things at once. So we're going to regenerate. But in situations like this, we need to decide as well, how am I going to regenerate this area? because I don't have any buccal wall, I don't have any palatal wall, and I don't have any distal wall from the canine. So at this point, what I'm going to do is I'm going to open a flap. This is a full thickness flap. I eliminate and curette all the granulation tissue that was developed due to the extraction and the periodontal defect and periodontal problem and all that bone loss that was developed because of that fracture that the premolar had. And this is what I see. I see a huge buccal defect. I have a lingual wall, that palatal wall that is lost, and I have a buccal wall, and also have a distal wall of my canine that has a attachment loss, important attachment loss, even though the canine is not mobile. So at this point, this is going to be my planning. First, I'm going to regenerate in order to be able to place my implant after 6 months after the regeneration. And in order to do that, we must understand the biology. And this is why I consider that whenever we are trying to regenerate an area, an atrophic site, an atrophic ridge, or a combination of atrophic ridge in addition to a periodontal defect of an adjacent tooth like this one, we need to understand the biological width environment. And by understanding the biological width definition, we should be more predictable. We must know that the Sharpie fibers develop from the cement that it's on the root surface, and they engage the bone at the periodontal ligament level. And we're going to have some supracrestal fibers that are also going to engage to attach to the cement. And in order to be predictable, as I said before, we should understand biological width definition and all the components that make this environment sustainable at long term. So when we need to regenerate specific site, we need to try to apply the biological concepts. And when I say that we need to apply the biological concepts, I mean that by understanding also the types of defect, one wall defect, two wall defect, three wall defect, or combination or a crater, combining all the wall defects in between, you already know the chances that you have in terms of the potential regeneration. So in this case, this is a combination of 1 to 2 wall defect. Obviously, in situations like this one, I'm not expecting to have a new reattachment or new periodontal ligament development unless I use specific biactive modifiers such as the Emdogain. In this case, we were not able to use Emdogain because of the economic limitations of the patient. When we asked the patient, listen, we can use a lot of things here, and if you want to preserve that canine, we're going to need to use these products, and I'm not going to charge you with that. The patient said, I have no money and I need to do something with this. And I felt really encouraged to try to look for an alternative to Emdogain, even though I really trust in this product. But in this case, we were not able to use it. First, because of the high cost of the Emdogain. But I want to mention that in this case, Emdogain was going to be one of the materials that we were going to use in order to get some periodontal ligament back, periodontal ligament formation back, and some new Sharpie fibers to have a new attachment of that tooth. So assuming that limitation, we decided to use one thing that I have been using for the last 8 years, which is growth factor therapy in most of my cases and most of my regenerative cases. And I personally, the good thing about the growth factor therapy, because we went by a specific generation time when nobody trusted on growth factor therapy, because maybe some described growth factor therapy with some definition that is not accepted by the literature. But in this case, the properties and advantages of using growth factor therapy compared to not using growth factor therapy, especially when we are performing a GBR technique, regardless of the type of biomaterial that you're using, are many advantages. Agglutinative properties. It increases angiogenesis. It has a biological, biomolecular effect, actually. And we are clinicians, and we are working on a living body. So we should use this type of bioactive modifier as well in order to get some good advantages compared to not using it. So personally, the one that I use PRGF from Dr. Nicolas, a BTI product, BTI from Endoret. But if you look at the literature, you're going to see many different combinations or many different definitions of growth factor therapy, and some PRP from Robert Marks in 1998 or PRF from Chokroun or PRGF are different models or formulas depending on specific changes and difference between the concepts. For example, in PRGF, we do not keep the leukocyte phase inside the clot because we consider that it belongs to the osteolysis or lysis activity of the cells. So we decide not to use that part of the clot compared to the PRF from Joseph Chokroun concept. Also, the time of release, the releasing time of growth factors. How long does the clot keep releasing growth factors? And these are differences between the concepts that actually were the ones that have been competing for the last decade, and especially the last late decade. The one that I use is quite simple. We draw 20 milliliters of blood from the patient. We centrifuge, and then I get some plasma and also some erythrocytes. So what we want to do is we want to just recruit the plasma clot and leave the erythrocytes or the red cells behind. And one of the applications that I use the most is for perioperatory complications from sinus lift, such as a membrane perforation, for example. This is a very, very predictable way to increase the thickness of the Schneiderite membrane, and is a very, very predictable way to keep performing your sinus lift regardless how big your perforation is. Obviously, you have some limitations in terms of perforation of the membrane. You cannot have a big hole, but most of the situations when you might end up with a accidental perforation of the Schneiderite membrane, you're going to be able to apply as many clots as you have in order to block that potential migration of particles inside the sinus, which might cause some complications. So one of the applications would be to protect the Schneiderite membrane, and also I use it to agglutinate the particles when I perform a GPR, which is the case that I'm presenting today. This is, for example, a trophic rich Sievert 1 defect with a severe atrophy in the buccal aspect, and we decided to do a GBR using growth factor therapy. And this is the way that it actually looks when it's being hosted by the membrane that has been sutured to the periosteum. And the combination of using growth factor therapy with different biomaterials is very extensive. You can use allograft, xenograft, in addition with autogenous bone and PRGF. And in this case, I would have used all these kind of biomaterials because there's a lot of literature that explains and shows a great and amazing work when we combine biomaterials. The quick turnover into vital bone of the allograft, the long-term sustainability and long-term stability of the xenograft, and obviously the gold standard autogenous bone that actually increases the potential of regeneration, and the use of PRGF or any kind of growth factor therapy that you have available in order to agglutinate your particles and show a little bit more integrity of your graft are a lot of advantages that it has. And in this case, I used something that for this patient was going to be cheap. And when I say cheap, it's not because it was my decision, but I wanted to use, in this case, synthetic bone, beta-3CP, plus autogenous bone that I collected from the site, from the specific site, and I mixed it with PRP. And one of the important things that we need to take into account when we are doing a GBR right next to an area that we have a periodontal defect is the particle size as well. And by using a PRP clot, which is basically a plasma clot from the patient's blood in addition to a bone graft, you're going to be able to keep your particles in place, because one of the things that you want to avoid when you're performing a GBR is a micro movement. And micro movement will encapsulate your particles. And micro movement, it's something that you can reduce by agglutinating those particles into your clot. But sometimes it's not enough, and you need to not only keep your particles in place and not only to keep your graft intact, but you also need to isolate it and keep the shape of the ridge. And I used in this case a PTFE membrane, titanium reinforced. This is a PTFE membrane that worked perfectly. I love the texture of the PTFE membrane and how I could manage and manipulate the titanium reinforced back and forth without breaking it, which was something, some advantage that I saw, that I felt when I was using it. Obviously, whenever you have a defect like this one, you need to decorticate and make some osteotomies over your hosting bone, because you want to increase the blood supply and you want to bring some new cells from the hosting bone. And this allowed me to have a better scenario for my particles. I knew the limitations of the beta-2-3P in a three-dimensional defect, and this was quite a big risk, the one that I assumed by doing it, but I was trying to be predictable at the same time that I wanted to check the potential of this kind of bone graft. And I placed and I packed my small particles right next to the defect of the tooth defect site, which was an area that was very irregular. It was a tiny area, and I tacked my membrane. But I realized when I was stacking my membrane that I didn't have any palatal wall, right? So what I had to do at this point, not only to trim it, but I had to suture it and fix my membrane to the palatal side with a very, very deep periosteal suture. And my periosteal suture went to the periosteum, up to the periosteum, but also it went all the way over the membrane to keep the particles in place, to keep the shape of the ridge, to bring back that original shape, and also to host the membrane from the palatal aspect to try to regenerate that palatal wall, which wasn't impossible to tack my membrane, because regardless, I elevated a full thickness flap from the palate, and I did a mesial releasing incision. Sometimes it's really difficult to manage the palatal aspect because the palatal gingiva is really attached. So at this point, what I wanted to do was to extend my membrane over the ridge and also reach the palatal aspect and also suture it in order to bring a little bit more membrane to the palatal aspect to try to keep that palatal wall that was absent, to try to bring it back. Sorry. I used autogenous fiber membranes to cover my PTFE membrane for many reasons, because I want to have some extra tissue protection on the top of my membrane. Today you can also use some collagen membranes or pericardial membranes on the top of your PTFE membranes, just in case they get exposed. At least you have some extra tissue that is there in case of dehiscence. I don't want to go too fast, because one of the things that I want to say according to this slide, and referring about this slide, is the distal and mesial releasing incisions that I did. My mesial releasing incision, I considered that I had to do it in that area because I couldn't go farther forward, because it was the aesthetic zone and I didn't want to make any vertical incision in the aesthetic zone. And I had to do a mesial and distal as well, because I had to really see very well the area, but not to oversee. I didn't want to go too far away, because I didn't want to make a big flap. I wanted to stay in place, and I wanted to be a little bit more conservative in terms of flap management. And I considered that doing that vertical incision at the adjacent tooth next to the surgical site, even though it's not recommended, because you need to go a little bit farther away. You need to go a little bit farther just in case you have dehiscence. And the weakest areas are going to be the mid-crestal incision area, and also the vertical incisions, which are the most, the ones that actually are lacking of blood supply. You're blocking the blood supply by doing these vertical incisions, and obviously you have more risk of having a dehiscence in that area. And if you have a dehiscence, you might have some bacterial proliferation inside. But I decided to do it this way because I considered that I could manage the flap properly. And in another scenario, I would have gone a little bit farther away, especially on the distal aspect, to move away a little bit more from my surgical site. So as I said before, I put some ectogenous fiber membranes, and then I did some releasing, a periosteal releasing incision in order to be able to manage the flap properly. And this is something that I learned from Dr. Joseph Shukroon, which is whenever you're using nylon, I never use silk, because I consider that the silk also brings a lot of bacteria. I also use, I only use nylon in different sizes. And in this case, I use nylon 4-0, and I leave the nylon very, very long, because if you leave it short, that might pinch the patient, the mucosas patient. And sometimes you are even doing minimally invasive surgeries, not in this case, but you're doing minimally invasive surgeries, and the patient actually refers the postoperatory inflammation or postoperatory pain is addressed to the sutures and not to the surgical site. So by leaving those long nylon sutures, you're going to make those sutures to adapt to the mucosa and to the gingival and the vestibule, and they're not going to pinch the inner lip, the inside of the lip. So this is the way that it looks. I don't see a lot of tension. This is something very important to see, not many ischemic areas when you're doing a closure and you need to release your flap and relieve by doing a periosteal release in order to have primary closure and free tension. This is something very, very important, especially because you are using a PTFE membrane that if it gets exposed, you know, it's not a problem when it gets exposed after the second month or third month, but if it gets exposed after 2 weeks, you're gonna have to deal with an opening, and you don't want that. So this is how it looks after 6 months. So I didn't put any soft tissue grafting. I didn't put any connective tissue graft, and what I see after 6 months is a quite nice scenario. Now I can take a CT scan, measure the ridge, and plan my surgery that I'm going to perform with an AnyRidge 4x13 millimeter implant. And these are the two pictures that I documented to see the before and the after, and look how I even move the mucogingival junction, the curve, that convex situation, and that mucogingival junction line, how it's migrated to the palatal aspect, and how we actually made it to migrate, and we have plenty of keratinized gingiva. So what I decided to do after that was to reopen, and the reopen was quite difficult. The reopening, as you can see, I didn't use a distal incision, because when you are reopening a situation like this, you don't need to see too much. You only need to work on the surgical area, and you don't need to tack anything. You're going to remove that membrane. And one of the things that I see, especially when you're using a biomaterial that regardless you kept it away from epithelial cells and epithelial growth, and you fixate the membrane to avoid micro movement of your particles. When you don't see a bone graft that is incorporated into the surgical site, or you don't see a mature or cortical, even cortical bone, that's something that I see when I use autogenous mixed with xenograft, or allograft mixed with xenograft. Compared to when I use a synthetic bone particles, is that whenever I opened, what I saw were especially particles in the most coronal aspect, the ones that actually did not receive much blood supply, and regardless, we isolated those particles and we fixate the membrane. We avoided micro movement and micro motion of those particles to avoid that encapsulation. The most coronal aspect of the surgical site is not going to receive much blood supply. First, because we are blocking the blood supply with the PTFE membrane from the periosteum. And second, because those particles are receiving the blood supply from where? From the distal aspect of the canine, which is a tooth that doesn't have any blood supply. But also from the coronal, the most apical aspect, that I had particles as well. So you're going to have a better incorporation of your particle bone graft as you move apically. So as you move coronally, you're going to have less osseointegration of your particles, especially using a synthetic bone that in three-dimensional defects does not have the potential of a quick turnover and incorporation, regardless if you're using it mixed with autogenous bones such as the one that I used. So that didn't avoid to see a nice aspect of the surgical site. And when I see the comparison, and when I see my previous surgery, I see a quite nice regeneration. But the question is, will I ever have any new attachment distal to the canine? Because this is something, a canine is a tooth that works for the rest of our lives, especially when we have a single canine, natural canine. We have a canine guidance, so we need to protect it. And for me, it was a mandatory, at least to ask myself, will I ever have either attachment, new reattachment, without using any endogain or anything? Will I ever have what will I have? So I consider that in this case, I'm going to have long junction epithelium all the way down to the apical aspect. So I placed my implant. That was the defect area. As you can see, the implant was placed in order to be a screw retain crown. And I didn't place any additional bone graft. That's the bone graft that I had. And I assume that those particles maybe down the road will turn over into vital bone and will keep hosting my implant down the road. So, as I said before, I only made a mesial releasing incision, mid-crestal as well, and intrasulcular incision on the distal. But I didn't do any distal releasing incision. I closed the area. I didn't place any additional bone graft. And this is what I see, and this is what I like to do whenever I do also a regeneration and then I place my implant. And I want to see what's going on, what biologically, what it's being supported. And what I see in this case is a external tooth resorption. And when you're encouraging a lot of bone regeneration, you know that the pre-osteoblasts are the osteoclasts. So you're going to increase the osteoclast activity previous to the bone regeneration. And I have hyalinization in this case, like what we say in Spanish, rizolisis. So root resorption, external root resorption, that has like a front on the distal aspect of my canine. This is something that we need to control over time. So the follow-up of this patient, it's mandatory, regardless how much bone I have on the most coronal aspect, as you can see. So whenever we're taking pictures or whenever we are doing some x-rays, it's not only to be so happy with the bone that I see. If you see the big picture, and in this case, this is what I wanted to see, I saw an external root disruption. And that was the bad thing about it. So we need to think about that and obviously keep that patient in follow-up for that issue. So going back, this is the CT scan and the control CT scan. And as you can see, we basically regenerated the whole buccal plate. And I was really happy because in a situation like this, even though I wasn't using the appropriate biomaterial, the best biomaterial that I could use because of those economic reasons, and I wanted to test how far can I go with this synthetic bone in a three-dimensional defect, I got such a great result in terms of diagnosis or radiological control. And this is 1.5 years after placing the crown. This is the number 24. This is the preapical x-ray that we took, the last x-ray that we took. That's the canine. That's the bone on the top of my implant. That is the screw retain crown in place. And that is the new reattachment. Is that long junctional epithelium? Probably yes. Probably I'm having all the way down long junctional epithelium. So I consider that here by using maybe Emdogain, it could have been even better for the outcomes, especially in order to try to regenerate the PDL. Because I consider that in this case, I didn't have any PDL regeneration. But at least I have a nice control. As you can see from the canine, still sometimes some particles come out, but the patient is stable. And what I see in situations like this is that I have a natural anatomical topography. So I brought back, even though it was limited in terms of type of biomaterial, I considered that we performed properly the surgery and the decisions that we made in terms of staging our approach as well. But we brought back the original architecture and the scallop gingiva. We tried to manage it, and I consider that we actually managed it quite well. So we have now stable keratinized tissue around my implant, and I also have some insertion. I have some at least soft tissue attachment, soft tissue apposition on the top of my canine, but at least this patient, it's very, very stable. So some conclusions after this case discussion. I would say that the type of defect, it's very important whenever we are doing and performing a regenerative procedure adjacent to a tooth that is affected because of that atrophy adjacent to the tooth. We should understand the biology, and we should understand the periodontal biological width environment in order to make the appropriate decisions. The outcomes. I consider that the outcomes are multifactorial, but sometimes the economic limitations, and when I say economic limitations might affect the outcomes, is because this is something that we don't have the perfect patient, we don't have the perfect case. We have to deal with these kind of situations, and whenever we are assuming that I'm going to try to regenerate this patient and I'm going to try to place my implant, I need to make specific decisions that sometimes are limited and unaltered because of that economic limitations from the patient's perspective. And we need to deal with that. And whenever we deal with that, we should assume that some risks might affect our outcomes as well. So that economic limitation would affect and alter the outcomes. And obviously the proper management and biologically oriented decisions. For me, it's mandatory. It's not how good also the material is, the one that you're using, or how bad it is. Sometimes is the proper management and try to use the biological concepts to try to understand what is the best for the patient. And if I cannot acquire the best thing for the patient, at least to have an alternative that fits into my patient's treatment planning. So I want to thank you very much for being there. I want to appreciate and I want to say thank to Dr. Park for this amazing idea of having case discussions among the MINIC and some new members that are invited to come. And I hope that you enjoyed, and I'm looking forward to see you in the next case discussion. Bye-bye, and thank you very much. Bye-bye.